Good morning and welcome. So what I'll do is give you a brief overview of the 2016 European guidelines. But as we speak, these are being revised and we'll be having the new set of guidelines in 2019. Now, prevention of atherosclerotic vascular disease is possible only with optimal risk factor modification. And although we will be focusing on dyslipidemia, we definitely should not neglect the other risk factors. And here you see the treatment targets and goals for cardiovascular disease prevention in the European guidelines. There is strong and consistent evidence from genetics, clinical studies, and epidemiology showing that LDL is causal for atherosclerotic vascular disease. And we summarize all this evidence in our 2017 consensus paper. So this is why LDL is the primary target, dyslipidemia target in our guidelines. In general, clinical evidence suggests that absolute risk reduction for cardiovascular disease depends on the individual risk of the patient, the baseline LDL, and the extent of lowering. So most of the guidelines take as the main principle to determine the risk of the patient first, plan the treatment intensity according to the risk of the patient, and target LDL and in some guidelines non-HDL as well. In Europe, when we were writing the guidelines, we decided to take into account all the published data and translate the scientific evidence to clinical practice, setting individual goals. So our guidelines are tailored, and patients and physicians, we strongly believe that, need goals for follow-up and adherence. The ACC-AHA approach in 2013 was slightly different. They took into account only data from randomized controlled trials, focused on the drug or fixed dose tested in this trial. In a way, this was simplified and easy for the general practitioner. And another advantage was that the low risk but high lifetime risk patients were covered in primary prevention, but also exposed a large population to statins. Now, in the European guidelines, LDL cholesterol is the primary target for treatment. However, non-HDL and ApoB can be considered as secondary targets, especially when ApoB is available. HDL cholesterol or its ratios are not recommended as targets. We have to determine the risk of the patient first, and throughout the world, there are several risk determination methods which work pretty well for the population they were derived from, but none of them are perfect. In Europe, we use the score system because it can be recalibrated according to this country's data, and it looks at the 10-year fatal cardiovascular risk. If the patient already has atherosclerotic vascular disease, diabetes with end organ damage, or severe kidney disease, there's no point in risk stratifying. They are automatically at very high risk. Also, those with a score risk of more than 10% are very high risk. If the patient has a markedly elevated single risk factor, like familial hypercholesterolemia, they're also automatically high risk, as well as the other diabetics and the ones with moderate kidney disease. If the score risk is between 5 and 10%, these patients are also at high risk, and the rest is moderate or low risk. LDL is the primary target, and in patients with very high risk, LDL goal is less than 70 milligrams per deciliter, or a reduction of at least 50% if the LDL is between 70 and 135. If the patient is at high risk, the goal is this time less than 100 milligrams per deciliter, but a reduction of at least 50% is also recommended here if the LDL is between 100 and 200. And in the other subjects, the goal is less than 115 milligrams per deciliter. In the European guidelines, there is a large section on familial hypercholesterolemia. We know that it is underdiagnosed and undertreated, and much more prevalent than we think. So we have the simple clinical criteria, even if you do not have the genetic testing, to diagnose these patients who are exposed to huge loads of cumulative loads of LDL cholesterol throughout life. Lifestyle plays an important role, and there's a large section in the guidelines on lifestyle. Things like reducing dietary fat, saturated fat, increasing fiber, increasing physical activity, or reducing weight play an important role in decreasing LDL cholesterol levels. We also have several different medications to lower LDL cholesterol, but there is more evidence with those increasing LDL removal. For the pharmacological treatment, prescribing statin up to the highest recommended or tolerable dose is a class 1 important indication. In case a patient has statin intolerance or is unable to reach the goal with a statin, then ezetimibe or bile acid sequestrants may be considered. At the time the guidelines were written, we didn't have the outcome data with PCSK9 inhibitors. So there's a very general saying that if the patient is at very high risk and persistent high LDL, despite treatment with maximal lipid lowering, then PCSK9 inhibitors may be considered. We know that statins decrease LDL cholesterol around 30 to 50%, depending on the dose and statin, and there's extensive evidence they have cardiovascular benefit. But recently, there has been some reluctance on the patient and the physician's side on going up to the highest dose of statin. So this year, we wrote a consensus paper in the European Heart Journal showing the risk-to-benefit ratio of statins, as well as another paper on how to cope with statin-associated muscle symptoms. But in general, we can say that the established cardiovascular benefits outweigh the risk significantly. We also have learned from a meta-analysis of 8 large statin trials that there is a variable response within the patient, even to intensive statin therapy. And in these trials, 40% of the patients did not get to the goal, but we know getting to goal is important. So additional lipid lowering can achieve what statins cannot achieve consistently. The IMPROVE, it was one of the first trials to show that non-statin lowering events, and even lower is even better. And the subgroup analysis from IMPROVE it also showed us that there is a subgroup of patients who can benefit from further reduction of LDL below the usual guideline goals. And just looking at simple clinical parameters as shown here, it is possible to think of who will benefit and who will derive greater benefit. Evidence of benefit from further lowering came from the PCSK9 outcome trials. And in these very high-risk patients on optimal lipid-lowering therapy, it was possible to get even further benefit in terms of cardiovascular outcomes. Both the Fourier and Odyssey studies showed this. And in a post-hoc analysis of Fourier, interestingly, there was no threshold for benefit. So as you see here, even if the patient went down to very low levels, the benefit was continuing. As Larry alluded to, the